Disorders of venous circulation. Venous thrombosis, chronic venous insufficiency. Varicose veins. L and B pages 1010. Olds. Venous thrombosis, thrombophlebitis. Condition in which a blood clot, thrombus, forms on wall of vein and partially or completely blocks flow of blood back to the heart, more common. Usually due to slow movement of blood. Thrombi can form in either arteries or veins. Platelet aggregation is more likely due to the slower movement of blood. Factors associated, see box 33-5. Bed rest. 4 catheters. Immobilization. Obesity. ME. CHF. CA of breast, pancreas, prostate, ovary. MS. Oral contraceptives. Pregnancy. Childbirth. Surgery greater than age 40. Altered coagulability states. Pathophysiology, Virchow's triangle. Status of blood. Increased blood coagulability. Injury to vessel wall. 2 of 3 factors must be present for thrombi to form. The pathologic factors associated with thrombophlebitis are, increased blood coagulability, stasis of the blood, and occlusion of the vessel wall. Injury to the vessel wall. Vasodilation of the vessel wall. Vasoconstriction of the vessel wall, a thrombus forms. Trauma to the lining of the vein brings tissues in contact with platelets that aggregate. Deposit of fibrin, leukocytes and erythrocytes into the platelet clump causes a thrombus. At first, the thrombus floats in the vein. Within 7 to 10 days it sticks to the vein wall, but a portion may still float in the vessel. Pieces may break loose and become traveling emboli. Fibroblasts invade thrombus, scar the vein, and destroy venous valves permanent. Deep vein thrombosis, DVT. Most likely to occur in deep veins of the calf, 80%. 25% of thrombi that occur in calf will extend to the popliteal and femoral veins. B may be the first sign of DVT. Question: the most common site for the formation of thrombi seen in deep vein thrombosis are the deep veins of the groin area, thigh, abdominal cavity, calf. DVT manifestations. When clot is in formative stage, may notice no symptoms. Usually profound tenderness, affected extremity may be larger, unilateral edema. Dull aching ESP when walking, most common. Severe pain, ESP when walking. Cyanosis of extremity. Slightly elevated temp. General malaise. Study guide. A client is told that she has a venous thrombus and must be on bed rest. She tells the nurse that she is much too busy and can't stay on bed rest. The best response by the nurse is, activity and exercise may cause life-threatening complications. Homan's sign was long considered classic manifestation. This is no longer true. Sign is not specific to DVT and can be elicited by any condition of the calf. As calf muscles contract, there is risk of detaching thrombus from the wall. Major complications of thrombophlebitis. Chronic venous insufficiency. Pulmonary embolism. Superficial vein thrombosis, SVT. Thrombi form primarily in upper extremities. Primary cause, trauma to venous wall with venous catheters, repeated venous punctures. Use of strong force solutions that produce inflammatory response. SVT manifestations: dull, aching pain over affected area, key. Marked redness along vein. Increased warmth over area of inflammation. Palpable cord-like structure. More immediate attention is required if edema, chills, high fever, suggests complications of inflammation. Question: a client with superficial vein thrombophlebitis is experiencing chills and a high fever. What infective agent is most often associated with the bacteremia that causes superficial vein thrombophlebitis? Clostridium, Streptococcus, Staphylococcus, Candida. Collaborative care, thrombophlebitis. Texas focus, inflammatory process, prevention of further clotting, extension and restoration of blood flow. Must be differentiated from cellulitis, calf strain, contusion, lymphatic obstruction. 3. Medtexis, use of meds, treat inflammation/infection, dissolve clots. Lab and diagnostics: duplex venous ultrasonography, plethysmography, LG in superficial veins, magnetic resonance imaging, ascending contrast venography, most accurate, Doppler ultrasound. Question: which examination is the most valuable in the detection of large and superficial veins? C. Plethysmography. Conservative therapy, SVT. Prophylaxis, LMW heparin. Prevention is key. Post-op clients leg exercises, DEDs, ambulate ASAP, no leg crossing, loose-fitting clothes, exercise. Focus, relief of symptoms and reversal of inflammatory process. Apply warm, moist compresses over affected area and administer anti-inflammatory agents as prescribed. Some clients may require antibiotics, therapeutic or prophylactic. Question: a 63-years-old male is being treated for a superficial thrombophlebitis of his left arm believed to be caused by repeated 4 catheters. As a part of his pain control, the nurse provides him with naproxen and a sling, a rubber ball to do hand exercises, a warm compress, an ice bag. Conservative therapy, DVT. Anticoagulants may be prescribed for severe cases. Strict bed rest until symptoms of tenderness and edema resolve. Legs elevated, knees slightly flexed, above heart level to promote venous return and discourage venous pooling. DEDs or pneumatic compression devices. Question: a 38-years-old female is being discharged from the hospital after being successfully treated for a DVT of her left leg. The nurse preparing her discharge instructions should advise her to cross her legs only at the ankles to avoid further thrombus formation. Sit at a 680-degree angle to prevent further thrombus formation. Wear support hose to help prevent further thrombus formation. Break up long periods of sitting with short walks to prevent further thrombus formation. So exercise is your best preventative measure. Anti-inflammatories, anticoagulants, thrombolytics, antibiotics. Medications: anti-inflammatories, anticoagulants, thrombolytics, antibiotics. Anti-inflammatories: NSAIDs, indomethacin, indocin, naproxen, naproxen. When used with warm, moist compresses, NSAIDs bring symptomatic relief to most clients with SVT. Anticoagulants. For DVT, most common Texas to prevent propagation of thrombus and subsequent P. Initial bolus of 7,500 to 10,000 U of heparin, then continuous heparin infusion started, via pump. Daily dosages calculated based on results of APTT, activated partial thromboplastin time. Desired APTT is 1.5 to 2 times normal APTT value. Oral anticoagulation with warfarin is started first week, important to overlap 4 to 5 days, full effect of warfarin is delayed. Warfarin, PT should exceed normal value by 1.5 to 2.5 times/inner 2-3. Oral anticoagulant Texas may last from 2 to 6 months, depending on extent of disease, single occurrence versus P. Thrombolytics. Dissolve blood clots by imitating natural enzymatic processes. Have been shown to destroy venous thrombi that are less than 72 hours old. More rapid and efficient than heparin while also preventing additional damage to venous valves. Side effect of hemorrhage is more common than with conventional heparinization. Antibiotics limited to specific texts of identified infections. SVT, develop bacteremia, Staphylococcus. If blood cultures are positive, antibiotics are started to prevent systemic sepsis. Surgery. Most clients are Texas with meds and conservative Texas. Venous thrombectomy, done when thrombi are lodged in femoral vein and excision of clots is required to prevent P or to prevent gangrene. Also can insert filtering devices into inferior vena cava via femoral or jugular vein, used for Ps who can't take anticoagulants and are at risk for P or have recurrent problems. Most common filter used, Greenfield filter, a SOC W/97% success rate in preventing the recurrence of P. Nursing process. Addresses clients' responses to illness, primarily in areas of pain MGT, education disease process/med Texas, and interventions to reduce inflammation and prevent complications. Prevention is very important. Provide info causes to venous thrombosis to all high-risk clients, nursing diagnoses pain and effective protection. Impaired physical mobility. Risk for ineffective tissue perfusion, peripheral pain, RT inflammation of vein caused by thrombotic process. Assess client level of pain on regular basis using 0 to 10 scale. Measure diameter of calf and thigh of affected extremity on admission and QD. Apply warm, moist heat to extremity for XQD, compresses or aqua-K pad. Maintain BR and teach client rationale. Study guide, with a venous occlusion of the calf, the most appropriate nursing intervention is to maintain bed rest and provide ROM exercises. Ineffective tissue perfusion, RT obstruction of blood flow and triggering of inflammatory response and subsequent swelling/pain. Assess peripheral pulses, skin integrity, capillary refill times, and color of extremities at least once Q shift. Elevate extremities, keep knees slightly flexed and legs above heart level. Maintain use of TEDs as ordered, remove only for short periods, 30 to 60 minutes, during daily hygiene. Use of mild soaps, lotions to clean leg/foot. Assess skin Q shift. Positioning aids, egg crate/sheepskin. Ineffective perfusion, result of obstruction of blood flow and triggering of inflammatory response and subsequent swelling/pain. Administer and monitor effectiveness of analgesics, anticoagulants, thrombolytics, antibiotics. Before administering anticoagulants, check lab values, APTT/PTIT. Position changes Q2 hours while awake. Study guide, which APTT level indicates effective anticoagulation therapy for DVT. Control 20, Client 48. Control 22, Client 28. Control 24, Client 60. Control 18, Client 36, impaired physical mobility RT prolonged bed rest, constipation, joint stiffening, muscle atrophy, boredom. Encourage active or perform passive ROM exercises at least 1 X shift. T.C. DB at least 4 shift while awake. Increase fluid intake and dietary fiber. Provide progressive ambulation within ordered guidelines. Diversional activities. Other nursing DX and effective protection RT anticoagulant Texas. Monitor lab results, INR, PT, IPT, H&H. Assess regularly of evidence of bleeding. Risk for ineffective tissue perfusion, cardiopulmonary. Frequent assessment of respiratory status, RRD, and O2 sat. Chronic venous insufficiency. Disorder involving stasis of blood in lower extremities as result of obstruction and reflux of venous valves. 2. A SOC with changes in venous circulation resulting from thrombophlebitis and valvular incompetence, varicose veins, clinical manifestations. Lower leg edema. Itching. Brown pigmentation/cyanosis of skin of lower leg/foot. Fibrosis/hardness of subcutaneous tissues. Stasis ulcers over ankle, most often medial. Study guide: the presence of stasis ulcers in the client with chronic venous insufficiency can best be explained by lack of exercise in the affected extremity, congestion of blood in the affected extremity, pressure applied to the affected extremity, increased temperature of the affected extremity. Complication: ulcer development. Blood pools in lower limb and peripheral circulation slows, insufficient oxygen and nutrients to cells. Cells die, causing formation of venous stasis ulcers. In attempt to heal stasis ulcer, body increases supply of oxygen, nutrients, and energy to area, but it does not reach the diseased tissues due to impaired circulation equals enlarged ulcers. Complication: ulcer development. Congested venous circulation prevents biochemicals from immune system to diseased tissues, interfering with normal inflammatory response. Increases risk for wound infection. Area around stasis ulcers appear shiny, atrophic, and cyanotic, with brownish pigmentation. May have eczema or stasis dermatitis, scar tissue. Slight trauma will result in serious tissue breakdown. Assessment, lab and diagnostics. No specific labs or diagnostic tests. Diagnosis is usually based on clinical findings. Interviewed data. Family checks. Past medical checks. Physical exam, possible nursing diagnoses. Ineffective health maintenance RT, lack of knowledge. Ineffective tissue perfusion, peripheral RT, incompetent venous valves. Anxiety RT, inability to control chronic disease. Disturbed body image RT, edema and status ulcers. Risk for infection RT, ulcerations. Impaired physical mobility RT, pain and lower leg edema. Impaired skin integrity RT, stasis ulcers. Nursing intervention/teaching. BR, with feet elevated above heart level. Avoid long periods of standing walk as much as possible. Avoid anything that pinches skin, knee-highs. While sitting, do not cross legs and avoid pressure behind knees. Elastic support hose/DEDs. Follow guidelines for care of legs and feet, p. 1219. Study guide: which statement by the client with chronic venous insufficiency indicates the need for further teaching? I should elevate my legs while resting or sleeping. Okay. I should walk as little as possible. Not okay. I should not wear anything that pinches my legs. Okay. I should keep the skin on my legs clean, soft, and dry. Okay. Other interventions. Ulcer may be treated with semi-rigid boot applied to affected area. Device may be made of Unaz paste or Gauze-Tex bandage. Changed Q1 to 2 weeks. Surgery for large, chronic ulcers, incompetent veins ligated, ulcer excised, skin grafted. Medications, topical agents and/or antibiotics. Acute weeping dermatitis, wet compresses with boric acid, Burosan, isotonic saline 4-XQD for 1-hour intervals, followed with topical ointments, 0.5% hydrocortisone cream. Subsiding/chronic, continue use of hydrocortisone cream. Other, zinc oxide ointment, broad-spectrum antifungal creams, clotrimazole/lodoramin, miconazole/monistat. Ulcerations, saline compresses to promote wound healing or prepare for skin graft. Evaluation: the client verbalizes SS infection, remains free of infection. Verbalizes understanding of disease process, Texas, regimen, limitations and is compliant. Demonstrates improved perfusion, heaps skin color and reduction/absence of edema. Displays increasing tolerance to activity. Pain/discomfort relieved. Irregular, tortuous veins with incompetent valves. Varicose veins. Irregular, tortuous veins with incompetent valves. Varicose veins may develop anywhere in body, but most develop in lower extremities. Vein in legs most often affected. Long sappiness occur in 1 out of 5 people, more common females greater than 35, whites greater than blacks, familial tendency. Causes: severe damage or trauma to sappiness vein. Effects of gravity produced by long periods of standing. Types: primary, no deep veins involved. Secondary, caused by obstruction of deep veins, most common. Pathophysiology: major cause, sustained stretching of vascular wall due to long-standing increased intravenous pressure. Valves become incompetent because they cannot close properly due to stretching. Prolonged standing, the force of gravity, lack of lower limb exercise, and incompetent venous valves all weaken muscle pumping mechanism, and return of venous blood to heart decreases. As client stands for a long time, blood pools and vessel wall continues to stretch, and valves become increasingly incompetent. Normal versus abnormal. Clinical manifestations: severe, aching pain in leg. Leg fatigue and or heaviness. Itching over affected leg, stasis dermatitis. Feelings of heat in the leg. Visibly dilated veins. Thin, discolored skin above ankles. Complications: insufficiency, stasis ulcers, chronic stasis dermatitis, thrombophlebitis. Assessment, labs and diagnostics. No specific labs. Diagnostics: Doppler ultrasound flow tests and angiographic studies or duplex Doppler ultrasound. Trendelenburg tests assists with diagnosis. Collaborative interventions. Conservative measures include anti-embolism stockings and regular walking and leg elevation. Mild analgesics may relieve pain. Compression sclerotherapy and vein stripping are surgical techniques that may alleviate the major symptoms of varicose veins, however there is no cure. Nursing process focus: restore venous circulation, relieve symptoms. Prevent complications. Promote behaviors that minimize symptoms. Nursing DX, chronic pain RT, prolonged interruption and return of venous blood to heart and subsequent pooling of blood in extremity. Assess pain. Teach and reinforce methods for relieving pain that do not involve use of analgesics. Encourage discussion of possible relationships between pain and life stressors. Collaborate with client to determine pain control plan. Regularly evaluate effectiveness of interventions used to minimize pain. Nursing DX, ineffective tissue perfusion RT, insufficient supply of nutrients/oxygen and incompetent valves. Assess peripheral pulses, capillary refill time, skin temp, and degree of edema. Teach client use of anti-embolic stockings, remove daily for 30 to 60 minutes. Teach to exercise extremities at regular intervals. Teach client to elevate affected extremities to reduce tissue congestion and promote return of venous blood to heart. Study guide: a nurse is teaching a health education class. A participant asks how she can prevent varicose veins. The nurse should tell her that the best prevention is to A. Walk regularly and daily. Nursing DX, ineffective tissue perfusion RT, insufficient supply of nutrients/oxygen and incompetent valves. Assess skin on lower extremities for warmth, erythema, moisture, signs of breakdown. Teach about daily skin hygiene. Teach client to protect extremities from external forces that may cause skin breakdown. Encourage adequate nutrition and fluid intake. Nursing DX, risk for peripheral neurovascular dysfunction. Assess circulation, sensation, and motion in lower extremities. Teach to avoid flexing the extremity and to maintain positions that promote effective neurovascular function. Teach client/family to report and signs of impaired neurovascular function, such as numbness, coldness, pain, or tingling of extremity. Teach about importance of maintaining safety and adhering to plan of care. Other nursing DX. Risk for infection RT disruption in continuity of skin. Impaired home health maintenance RT prescribed postural limitations. Anxiety RT possible need for surgery. Evaluation skin is of normal color, damp, non-tender, non-swollen, intact. Client actively moves extremity, verbalizes reduced pain.